Good evening, all. In this session, we will take pharmacology, right? So, the very first question is about a clinical trial, and it has been asked like after which phase a new drug is introduced into the market, right? So, after which phase a new drug is introduced into the market. So, before that, we should know what are the phases of clinical trials. Now, there are four phases: phase 1, phase 2, phase 3, and phase 4. Clear? Now, whenever we are planning to introduce a new drug into the market, we don't know about the safety of the drug. So, in the very first phase, we have to check whether the drug is safer to humans or not, right? So, the very first phase is about safety. And what we will do here, we will give the drug to healthy subjects. Clear? So the drug is given to healthy subjects under ICU settings, because we don't know in what manner the drug will act on the body. So we have to make sure that we are ready with all the emergency measures in rare case if there is any side effect or any adverse effect which can be fatal to life, right? So the very first stage is, or very first phase is about safety of the drug, and therefore we choose the healthy subjects, healthy volunteers, and the drug is administered to them under ICU settings. Now once we are sure that there is no safety issue, then we move on to phase 2. Now in phase 2 we do drug exploration. Here we will study about what amount of dose has to be given, in what dosage the drug has to be given, right? So that is drug exploration. And now here we will try the drug on patients. Clear? In second phase, we will give the drug to the patients, and we just want to study what should be the better and the best way to get maximum effect of the drug. So drug dosage, drug frequency, everything will be studied in phase 2. Now once we are done with this and we have got the all the information about the drug as such, now we will move on to the phase 3, and that is comparison. Now, what is this comparison word? Because if you are planning to introduce a new drug, obviously there might be some other drugs which are already there in the market. So your drug has to be superior to them. Then only it's worth introducing this new drug, right? So you will do comparison with the already available options in the market. So that is known as therapeutic comparison. And once you are satisfied that this drug is better than the already available options in the market, you can introduce the drug into the market. So after phase 3, a new drug application is filled and the drug is released into the market. Clear? So it is phase 3, after which we will introduce the newly developed drug into the market. Clear? So this is phase 3. Again the drug will be given to patients. And now phase 4 is post marketing surveillance. So what happens, once you have introduced the drug into the market, there are many studies which can be done only on long-term basis, like drug interactions. We don't know how this newly introduced drug will react with some other drugs if they are concurrently given, right? So drug interactions, then idiosyncrasy. There might be some adverse effect which are genetically determined, that will come only on long-term study. So this is post-marketing surveillance, and this is a long-term study, of course. So these are the 4 phases of clinical trials. Phase 1 is about safety, phase 2 is about drug or therapeutic exploration, phase 3 is about therapeutic comparison, and phase 4 is post marketing surveillance. Clear? So the time when the drug is introduced into the market is after phase 3. Many times, rather than going for such a lengthy procedure, because maybe like after phase 3, when we do therapeutic comparison, we might come to know that this drug is not superior to the already available options in the market, and then at times we have to discard the drug. So what has happened, like we have unnecessarily worked on phase 1, 2 and 3. So to avoid all this hard work, now there is a concept of phase 0, which is known as micro dosing. Clear? So this is just a concept so as to make sure that whether to really work on that drug or not. So this tells us whether it is wise to undergo clinical trials for that drug or not. So this is phase 0 or micro dosing. So anyway, phase 3 is the answer to this particular question. Now another question which is helpful in obtaining a variation in sensitivity of response to different doses of a drug in different individuals. Now here what we are doing actually, we are trying the drug and in different doses, and then we are studying the outcome. So this all is studied with dose response curve for a drug, right? So this is dose response curve, or also known as DRC. Clear? So dose response curve, like what dose you have given and what response you have achieved. Clear? Now here you will be getting two important words. One is potency and another is efficacy. So many times you must have heard these two words, and many times we have question in examination also, like there will be a graph and then they'll ask you which of the following statement is true, and that relates to potency or efficacy. So to understand this, now here you have to make a graph, right? So you will make a graph like this on, now this is dose response curve. So this is the dose of drug, and in this axis we will count the response or the effect of drug. So this is dose response curve. Now here, suppose if we are giving one drug and this is the amount of the drug, it can give you this much effect, right? So this is the effect at this dose. Similarly, there might be some other drug which is which is given in this amount, and then it is producing the same effect, right? So here you can see there the drug A, you can say this is drug A, this is drug B. Now here you can see that a different amount of dose different dose of the drug A is needed, and different dose of the drug B is needed to produce almost the same effect. This is one thing, right? Then you can take it in another manner also, like if you draw this curve again, okay? So again this is the dose of drug, and this is the response or the effect of the drug. Now here you can take, suppose you can take a fixed dose, and you will see the response of drug A, and again at the same dose you can see the response of drug B. Clear? So this is the maximal response of drug A, and this is the maximal response of drug B. So here I have shown you two graphs where dose is same but effect is different, and in second graph I have shown you that effect is same but dose is different. Clear? So this is the dose response curve, or what you call DRC. Now, when I say that now if a drug is more on the left side of the axis, it is said to be more potent, right? So more potent if it is on the left position on the graph. Now here, this you see, this drug is towards right and this drug is towards the left. So it means the drug A is more potent than drug B. So this is in terms of potency. Clear? So the drug which is more towards the left is more potent the one as compared to the other which is towards the right, right? So this is about potency. Now the drug which is at a higher level as compared to the other drug will be more efficacious. So if I write, this is in terms of efficacy. Clear? So efficacy is in vertical and potency is in horizontal axis. Now how to define potency and efficacy? Now if you want to define potency, firstly study this graph. Now what you are seeing here, that one drug, so say this is 10 milligram and this is 20 milligram, okay? The effect is same. So what you can see that for drug A, 10 milligram is needed, and for drug B, 20 milligram is needed to produce same response. So it means we are getting the same response by using less amount of drug A. So that is known as potency. So potency means, so if we write potency, potency means amount of drug needed to produce desired response. Is that clear? So this is potency, amount of drug. The drug which is required in less amount will be more potent, right? So if we just write here, drug required in less amount is more potent, and therefore it is plotted on left side of the graph. So left side of graph. So whenever you have to discuss about potency of different drugs, the drug which is more towards the left side, means towards this side, will be more potent, and the one which is towards the right side will be less potent comparatively. Clear? So this is the concept of potency. Now moving forward to the efficacy. Now see, in efficacy what we are doing, the dose is say 10 milligram. So we are using same dose for both the drug, and then we are measuring the response. So here you can see there is this much difference between the effect. So for efficacy what you will write? Maximal effect, because we are measuring the effect. Maximal effect produced by a given amount of drug. Right? So here the amount of drug is same, and then we measure the effect. So you can remember it like this: effect, efficacy. Clear? So therefore the drug curve which is on upper side is more efficacious. Is that clear? And vice versa. Lower side less efficacious, right? So this kind of questions we have in the examination about comparing about the potency, comparing about the efficacy. So this is the concept. More towards left side, more potent. More towards upper side, more efficacious. Clear? So make sure you don't mix up in this concept. Clear? So if you look here, if suppose this is for drug B, this is for drug A, although this is different scenario, but still just considering the drugs. So it means the A is producing more effect as compared to B, and considering they are given at the same dose, so we will say that A is more efficacious than drug B. Clear? And for judging the potency, we will see the drugs which are producing same level of effect. So potency can also be checked if the drug is producing the same level of effect. So here we see that drug A and drug C, they are producing same response, but look at the dose. Clear? So look at the dose. Obviously we need very less dose of A as compared to the amount of drug needed by the C. So that's why we are saying that the A is more potent than drug C. So A is more potent than drug C because we need less dose to produce the same effect. Clear? So this is potency. So this is about potency, and in simpler terms, dose, and efficacy, effect. Clear? So for efficacy, remember effect. Is that clear? Now if we just summarize it in a better way, you can write potency in one column and efficacy in another column. And then the discussion is always in terms of two: dose, response. Now response is nothing except the effect. So what is seen in potency? Potency, the response is same and this is different. Clear? And in efficacy, the dose is same and the response is different. Is that clear? So this is how you can understand. And the discussion is always in terms of two parameters: what dose is needed, what effect is generated. Clear? So dose response curve, a very important topic. Please be good with this. Now, volume of distribution. Volume of distribution depends on lipid solubility. And if a drug is highly lipid soluble, it will spread to distant part of the body, and then we will say it has got high volume of distribution. Clear? And I think if you remember the mnemonic ADME, these are the 4 points which are discussed in pharmacokinetics. Clear? So this is pharmacokinetics. That is the effect of body on drug. So A is for absorption, D is for distribution, M is for metabolism, and E is excretion of the drug. Right? So this distribution is discussed under pharmacokinetics. And what is pharmacokinetics? Effect of body on drug. Clear? So this is pharmacokinetics, because there is another term, effect of drug on body, and this is known as pharmacodynamics. Clear? So there are two terms, pharmacodynamics, pharmacokinetics, right? So this is more lipid soluble, higher volume of distribution. Then moving forward to LD50. LD50. Now L means lethal and D is dose, and the word 50 actually tells us, like, out of the experimented animals, if what dose will kill 50% of experiment animals, right? So that is lethal dose. Dose that kills means that is lethal to 50% of experiment animals. Clear? So this is lethal dose. So we can write the dose also like this. So lethal dose 50. Clear? So here we can take LD50. So this is LD50, the concept of LD50. The dose that is lethal to the 50% of test animals or experiment animals. Now moving forward to zero order kinetics. So there are two terms, zero order kinetics and first order kinetics. So if we write zero order and here first order, and the difference is in terms of excretion of drug. Here in zero order, a constant amount is excreted, right? So constant amount is excreted. And in first order, a constant fraction is excreted. Clear? So amount, it can be say 10 mg, it can be 20 mg, etc. And fraction, it can be 15%, it can be 25%, etc. Right? So you understand the difference? Zero order, a constant value is being excreted. First order, a constant fraction is excreted. So please remember this. And you can remember F and F, right? So fraction. Clear? F for F. So if you look at the graphs, this is the graph of first order excretion, right? So this is first order excretion, and this is the graph for zero order excretion. So this is zero order, right? So a constant amount is eliminated in zero order and a constant fraction is eliminated in first order. Now what are the drugs which will show zero order kinetics? And again you can remember the like 0 watt power as the mnemonic. 0 is again for the word zero order kinetics. Clear? So this is zero order kinetics. And what can be like warfarin, alcohol, aspirin, theophylline, tolbutamide, and importantly phenytoin. Clear? So you can remember these examples with this mnemonic. Now moving forward to therapeutic drug monitoring. So therapeutic drug monitoring. Now what does this mean? Obviously we are we are having a close watch, that is monitoring. And therapeutic means we have to measure the plasma concentration. Clear? We want to see how much amount of drug is there in the blood. Why we need to measure? Because again, if we have that say the dose axis at one or left side of the dose, this is the minimum amount of drug that is needed to produce effect, right? And on the other right side, this is the maximum amount of drug that can be tolerated, right? So maximum tolerated dose and minimum dose needed for effects. Because if the concentration of drug is in this area, less effects, no beneficial effect of the drug. And if the drug concentration is increased, then there will be toxicity or side effects. So it is very important to make sure that the drug plasma concentration is in this particular range only. It should not go below this, it should not go beyond that. So this we have to check, and that is known as therapeutic drug monitoring. There are many drugs which are very beneficial, but only if they are maintained in a particular plasma concentration. So here you can see this is the minimum dose which is needed, and this is the maximum dose which is tolerated. So we have to keep the plasma range within this plasma concentration only. Then the drugs can be remembered by the mnemonic ADALACT. Clear? So there are certain important drugs which you need to remember. One is, of course, aminoglycosides, streptomycin group drug, then digoxin, cardiac glycoside, which is an inotropic agent, then A, anti-arrhythmics, then L, very important, lithium for bipolar disorders, then anticonvulsants like phenytoin, then chemotherapeutic agents, anti-cancer drugs, so chemotherapeutic, and tricyclic antidepressants. Clear? So you can just make your own mnemonic, but out of these, aminoglycosides, then digoxin, then lithium, anticonvulsants. These are very important from exam point of view. Clear? Then moving forward, ACE inhibitors are treatment of choice for all except. Now, they can be used in CCF, congestive cardiac failure. They can be used in diabetic nephropathy, which develops because of hypertension, right? ACE inhibitor should never be used in hyperkalemia. Clear? ACE inhibitors should never be used in hyperkalemia because they have the tendency to cause hyperkalemia. So if you give the drug already in a patient who is having hyperkalemia, there will be fatal hyperkalemia. Clear? And that's the reason why they should not be given along with any other drug which causes hyperkalemia. Clear? So don't give ACE inhibitors with any other drug which is also causing hyperkalemia, because in that case there will be fatal hyperkalemia. Example includes spironolactone. So don't give ACE inhibitors with spironolactone, because this is potassium sparing diuretic. So both will increase the potassium level, and that it will go to very fatal levels. So never use ACE inhibitors in hyperkalemia. Now, what are the members in ACE inhibitor group, which ends with pril, right? Like, so they ends with pril, captopril, ramipril, enalapril, fosinopril, lisinopril, benazepril, quinapril, right? So they end with pril. And the indications where they are used, obviously one is hypertension, then congestive cardiac failure, then myocardial infarction, prophylaxis of cardiovascular risk subjects, diabetic nephropathy, and scleroderma crisis. So the important ones are obviously hypertension, congestive cardiac failure, diabetic nephropathy. So these are important indications. And the side effects, one of the important side effect is potassium elevation, and this is what? Hyperkalemia. Clear? This is an important side effect. Then apart from that, they can cause dry cough, which is very important for ACE inhibitors. And at times, because of this dry cough, we have to discontinue the drug. So dry cough means there is no productive, or there is no sputum, there is only cough. Clear? Then there can be taste change, right? So, or renal failure, like that. So just remember these two important. This one is also very important to remember. Dry cough. Now moving forward, a lady noticed color changes in hand, and this goes from pallor to red, and especially seen when she is washing clothes in cold water. Now what is this condition? Color changes, and like initially there is pallor, then there is cyanosis, then there is redness. So what is this clinical condition? Yes, anyone? What is this clinical condition? This is white, this is blue, and this is red. This is classical description of Raynaud's phenomena. Very good, Bhavnesh, sorry. So this is Raynaud's phenomena. Clear? And this is specifically seen with cold. So when a lady will wash clothes, there will be these sequential color changes. So PCR, that's the mnemonic for this. And such patients can be benefited by calcium channel blockers. Clear? So for Raynaud's phenomena, we can give calcium channel blockers, right? Then moving forward, a patient developed arrhythmia, that is conduction disorder, and he is taking long digitalis since long. Now what needs to be done? Now remember, digitalis is one drug which is given for congestive heart failure, but the problem is that this is treatment for congestive heart failure, but the side effects are arrhythmias. Clear? So this is one problem with digitalis, and therefore we have to monitor the therapeutic concentration. So therefore we do therapeutic drug monitoring. Now for arrhythmias, we have plenty of options, whether it is fast arrhythmias or it is slow arrhythmias. Tachy means fast, brady means slow. Now usually we see tachyarrhythmias where we can give magnesium sulfate, which is the drug of choice. Apart from magnesium sulfate, we can also give either phenytoin, but most importantly lignocaine, right? So lignocaine or lidocaine. Clear? And for bradyarrhythmias, obviously we need to give atropine. So in this case, it can be MgSO4 or lignocaine. Clear? So MgSO4 is preferred, and we can also give lidocaine or lignocaine. So digitalis induced arrhythmias, very important side effects. Then moving forward, now these kind of questions are also there. A patient is taking multiple drugs, there will be certain side effect, and they will ask you to point out the drug which is causing that side effect, right? So here, a patient is taking indanavir, lamivudine, and ketoconazole. So he is taking these 3 drugs. Now, during the course of the treatment, he developed nephrolithiasis, right? Nephro means kidney, lithiasis means stones. Now, which drug is responsible for this? Now, here you need to remember one thing, that indanavir has high possibility of causing nephrolithiasis. So, indanavir has high possibility of causing nephrolithiasis. Ketoconazole usually causes gynecomastia, right? So although this is not that important here. So indanavir should be remembered in relation to renal stones. Clear? So please remember indanavir. Then moving forward, a patient of hypertension is taking some anti-hypertensive drug, and during the course of the treatment he developed cough. I think all of you can answer which anti-hypertensive drug causing dry cough we just discussed. This is ACE inhibitors. Clear? So this is any member of the ACE inhibitor group. Then moving forward, a 50 years old heavy smoker develops severe chest pain, and we know that for angina we give sublingual nitroglycerin or nitrates, and sub means below, clear, and lingual is of course tongue. So if we keep the medication below the tongue. Yes, Bhavnesh, absolutely right. This is, you can say, captopril. Clear? So any drug which ends in pril, right? So now moving forward to this question. So patient was given sublingual nitrate, and then the pain resolved very quickly. Now this nitroglycerin, how does it act? It acts by producing NO, that is nitric oxide. Clear? So it is acting by producing nitric oxide. So this is how it benefits in angina. Clear? Then moving forward, which of the following anti-asthmatic does not cause bronchodilation? Now, bronchodilation, see, if in bronchus there are smooth muscles, clear? And these smooth muscles are acted upon by sympathetic system and parasympathetic. Clear? Now this parasympathetic causes bronchoconstriction, and this sympathetic causes bronchodilation. So if we want bronchodilation, we will give one drug which will act in line with the sympathetic system. Very good, Bhavnesh. So we will give some drug which acts in line with the sympathetic system, and that is known as sympathomimetic. Clear? So it is acting as if the sympathetic system is acting. So here you can remember some drugs like salbutamol. Clear? Now, if we want to inhibit this constriction, or resulting in bronchodilation, we need to give anti-parasympathetic, right? So we need to give anti-parasympathetic, and in technical terms, we don't use the word parasympathetic. What we use? We use the word cholinergic. Clear? So we will give anticholinergic. Now what drug we can give in this group? We can give ipratropium. So this is just to help you understand salbutamol or ipratropium, why they are used here. Clear? So this is just to tell you why they are used here, because salbutamol is sympathetomimetic and sympathetic system causes dilation, so there will be bronchodilation. Ipratropium is anticholinergic. It will block the parasympathetic system. Since parasympathetic system causes bronchoconstriction, if it is blocked, there will be bronchodilation. So this is to tell you option B and D. And dariphyllene also causes bronchodilation. So the answer here is hydrocortisone. Perfect, Bhavnesh. Now, you can, if you wish, you can remember the classification of bronchodilators. Beta-2 sympathomimetics. Now, if we are using the word mimetics, means acting same, right? Or anticholinergics. Now, anti means acting opposite. So I think this will help you in understanding why we use beta-2 sympathomimetics or why we use anticholinergic in bronchial asthma, right? So the examples is for beta-2 sympathomimetics, salbutamol, terbutaline, bambuterol, salmeterol, formoterol. And for anticholinergics, we can use ipratropium and tiotropium. There is another class which can be used as bronchodilators. This is methylxanthine, which includes theophylline, aminophylline, choline, theophylline, hydroxyethyl theophylline, or doxophylline, right? So these are all phylline group. You can remember, like they all end with phylline, right? So these are bronchodilators. Therefore, our answer will be A, hydrocortisone. Now moving forward and continuing with theophylline. Now theophylline has got many drug interaction, because if suppose we are giving theophylline for asthma, and if patient develops some other condition, like if the patient develops tuberculosis and we have to start rifampicin, suppose. So what will happen? Now rifampicin is a microsomal enzyme inducer. So what it does, by inhibiting, stimulating these enzymes, it will increase the metabolism of theophylline. So what will happen? The amount of theophylline will decrease in the body because it is being metabolized. Now when the dose or the amount is decreased, now what will happen? The effect will be suboptimal, right? So there will be less effect. So if we wish to get back the effect, what we need to do? We need to increase the dose to get optimum effect. Clear? So this is one condition where a drug which is given along with theophylline is causing metabolism of theophylline, and therefore we have to increase the dose of theophylline. Clear? And this is classically rifampicin, which is causing decreased levels of theophylline, and therefore you have to increase the dose of the theophylline to increase the level of theophylline in the body. Clear? This is one concept. Now the question is about another concept where we want to decrease the dose of theophylline. It means there will be some drug, you can say it can be like cimetidine. Now cimetidine will decreased metabolism. Clear? It will decrease the metabolism. So what will happen? There will be increased level in body. And when the body levels are more, what do you need to do? You have to decrease the dose, otherwise there will be toxicity. So this is a very beautiful concept about the interactions of theophylline. Like for some drugs, we have to decrease the dose of theophylline because they are inhibiting metabolism of theophylline. So the levels of the theophylline in the body are already increased. So those drugs are ciprofloxacin, important ones I'll tell you. Ciprofloxacin, then erythromycin, then cimetidine, allopurinol. Remember these 3-4. And the one which will promote metabolism includes rifampicin, barbiturates, clear? And phenytoin as well. So there are certain drugs which will decrease the level, so we have to increase the dose. There are certain drugs which, if given along with theophylline, will increase the dose, increase the level, so we have to decrease the dose. Is that clear? So please remember this. This is two separate group of drugs, and therefore the effect on the theophylline is different. Moving forward, a non-vegetarian developed pain redness at the first metatarsophalangeal joint of the foot. Now the moment you have this kind of presentation, anything affecting the great toe is most likely to be a case of gout. And this is especially seen in people who take red meat. So this seems to be a case of gout. Now the person is having similar episodes before, so it means this is going towards chronic gout. And how the previous episodes were managed? They were managed by taking analgesic. And analgesic, especially NSAIDs. So NSAIDs, they are preferred, of course, in acute gout. Now in chronic gout, this will not work. Bhavnesh, absolutely right. Now in chronic gout, since there is increased uric acid, so we have to decrease the formation of uric acid. So we will try to decrease formation of uric acid. So we will try to reduce the formation of uric acid, and therefore we will have to inhibit some enzyme which is there in the pathway of formation of uric acid, and that enzyme is nothing except xanthine oxidase. And I think most of you must know that xanthine oxidase is inhibited by allopurinol, which is the drug of choice in chronic gout, right? So uric acid levels were also high here, and if you see, this is the area where the xanthine oxidase work, and finally resulting in formation of uric acid. And this is of course because of metabolism of purines. Clear? So this is metabolism of purines. The final effect is uric acid, and therefore we need to give some drug which will block this enzyme, so this conversion of hypoxanthine to xanthine or xanthine to uric acid does not take place. Clear? So that drug is allopurinol, or we can also use febuxostat. Clear? Now moving forward to monoclonal antibody, right? So monoclonal antibody. So you can see MAB. So you are getting this word MAB. So in any drug which is ending with MAB is a monoclonal antibody. Is that clear? So monoclonal antibody, right? So remember MAB, the term has been taken from the word itself, right? So the answer is very easy here. Yes, Chaitanya, this is rituximab. Now, the nomenclature of these monoclonal antibodies is very interesting. Many times you will have a particular word like rituximab. So what you are getting here? C-MAB, right? So this is the ending word here. Now, C-MAB, whenever you are getting this term, like rituximab, it means the drug is, of course, monoclonal antibody. Mab is coming in the end, and she means chimeric. So it's a chimeric mab which is having around 65% human component. Okay, so this is rituximab, cetuximab. Clear? So the moment you get this word, she, of course, mab is monoclonal antibody. She means she is taken from chimeric. Clear? This is one thing. At times you can get the word zumab. You might have this word zumab, like as we are getting it here, Bevacizumab. Again, mab is obviously clear. Now the word zoo means that it is humanized and nearly 95% content is human. So she means chimeric with only 65% human content, and if you have zoo, that is humanized 95% human component. Clear? So this is she-mab, zoo-mab. Then we can have mu-mab, and here the human component is 100%, right? So here this is mu-mab. So mu is humanized but 100%. Clear? So this is panitumumab, right? Then again we can have two in the nomenclature, and that is tumor directed, like cetuximab. Clear? So you are getting the word two here. So TU2, that stands for the tumor. Okay? So a very interesting nomenclature. Most of the terms, they are derived from the facts related to that drug. Okay? Then if there is Li and MAB, that is immune directed. Then if there is C-MAB, that is cardiovascular, like bevacizumab, so C is coming here. Then if there is V, that is virus directed MAB. Clear? So very interesting nomenclature. Then moving forward to another drug combination, imipenem plus cilastatin. Now imipenem has got a broad antibacterial spectrum. Why we add cilastatin? Because the imipenem is already producing good response. But the problem is that there is one enzyme in the kidney that is known as dihydropeptidase. Now this enzyme is breaking the imipenem. So the effects of imipenem are not coming. Now how we can get the effects of imipenem? If we block this enzyme. To block this enzyme, we give another agent, and that is cilastatin. Right? So cilastatin has such no antibiotic role. It is just blocking this enzyme so that there is no metabolism of imipenem and we are getting the effects of imipenem. Therefore, this is cilastatin plus imipenem combination which is given because we just want to block this dihydropeptidase enzyme in the kidney, right? So this is kidney. So therefore, if you see combination of drugs, it means one drug is given along with other drug for some particular purpose. Clear? Then moving forward to another question, where a child is having fast blinking and after that he kept staring for few seconds, and on electroencephalogram there is a spike and wave pattern. Now this is very characteristic of absence seizure. So if a child keeps on staring, it means that is absence seizure, right? And electroencephalogram will show spike and wave pattern. Now for absence seizure, what we need to give? We can give ethosuximide, and if it's not there in the option, you can search for valproate in the options. So these are the drugs which are given for absence seizure and very easy to identify. Steering, right? So we can give ethosuximide or valproate. Now, a patient of epilepsy was started on lamotrigine, right? And this is 50 milligram once a day. Then every 2 weeks, the dose is increased, and then the final dose is achieved, that is 200 milligram per day. Now, why we are following this? Because see, for lamotrigine, we are starting with 50 milligram per day dose, and then after 2 weeks, we made it say 100 milligram per day, and then say after another 2 weeks, we made it 150 milligram per day, and finally after 2 more weeks, we made it 200 milligram per day, which is the desired dose of lamotrigine. Now the question is that why we took almost 6 weeks to reach up to the desired dose, or 4 weeks up to the desired dose. This is because if you straight away give 200 milligram per day dose, there will be skin rash. Clear? So to avoid this complication, we are not giving the entire dose at once, we are gradually increasing it over a course of few weeks. So this is very important in relation to lamotrigine. Clear? Now moving forward, a boy has generalized tonic-clonic seizures, and this is for 8 minutes. Airway is open, but still the child is having seizures. Now what should be the initial step here to control seizures? Now if someone is having seizures for 8 minutes continuous, this is known as status epilepticus. Clear? So any value more than 5 minutes is status epilepticus, and we need to sedate the child. So we will give IV, either lorazepam or diazepam. Clear? So this is the initial step. We need to sedate the patient. So if the seizures are lasting for more than 5 minutes in a child of more than 5 years, that is the indicative of status epilepticus. And in status epilepticus, we need to give either diazepam or lorazepam, whatever is available. Now moving forward, a male has shooting pain on touching the face, on chewing, speaking, or even brushing the teeth. Now what is this clinical condition? The sensory area of the face. So face, chewing, speaking, brushing, this is all trigeminal neuralgia. Okay? So pain in the distribution of trigeminal nerve, and such cases should be managed by carbamazepine. Clear? So they should be managed by carbamazepine. Fine. Now, drug of choice for bipolar disorders. I think all of you must be knowing. Yes, Bhavnesh, absolutely right. Now, all of you must be knowing what is bipolar. Like if this is normal mood, then sometimes the mood is up. So this is mania. Or sometimes the mood is down. So this is known as depression. So this up and down is bipolar. Okay, so this is known as bipolar. Bi means two, polar means ends. So sometimes the mood is elevated, sometimes the mood is depressed, and for stabilizing the mood, we prefer lithium. Clear? So lithium is the mood stabilizer. Fine. Now we discussed that lithium. Yes, Bhavnesh. Yes, PUBG. Both of you are correct. Now we already discussed that lithium needs therapeutic drug monitoring. Why? Because if the dose is increased, there are many side effects. And one should be very good with the side effects of the lithium, which can be remembered like then the name itself gives you the probable side effects like increased WBC count, but what is more important? Tremors, hypothyroidism, increased urination, that is diabetes insipidus, and this drug is teratogenic. Clear? So if taken by a pregnant lady, this will result in Epstein anomaly in fetus. So it should not be given to a pregnant lady. That's very important. So these are the side effects of lithium. Moving forward, example of direct thrombin inhibitor. Now, the direct thrombin inhibitor is dabigatran etacylate. There is another class that is indirect thrombin inhibitor, and that is unfractionated heparin, right? So direct and indirect thrombin inhibitors, and by blocking thrombin, they block the conversion of fibrinogen to fibrin, that is to fibrin strands, that is actually thrombus, right? So direct thrombin inhibitor, dabigatran etacylate. Now, which diuretic acts by inhibiting carbonic anhydrase enzyme? Now this is acetazolamide, and this drug is better used to prevent high altitude cerebral edema or high altitude pulmonary edema. Clear? So this is better used for these conditions, and it is given prophylactically. It means like if you are going to Leh Ladakh, you have to start this drug before going to Leh Ladakh, maybe around 2 days before. There is no usefulness if you start this drug after reaching Ladakh. So it has to be taken prophylactically. Clear? Yes, Chaitanya, absolutely right, acetazolamide. So we can take the classification of diuretics. One is osmotic diuretics. The member is mannitol, clear, which is used in raised intracranial tension. Then carbonic anhydrase inhibitor, that is acetazolamide, sold with the name of Dimox. Then there are loop diuretics which act on the loop of Henle, especially is furosemide. Then there are thiazide and related diuretics, especially hydrochlorothiazide. Then potassium sparing diuretic, we already discussed about spironolactone and its interaction with ACE inhibitors. Okay. Then ADH antagonist, this is conivaptan, or ACE inhibitors, that is all the prils, or the angiotensin 2 receptor antagonist, that is sartans like candesartan, losartan, or valsartan. Anyway, now moving forward, a known case of tuberculosis is showing resistance to isoniazid, rifampicin, kanamycin, and ciprofloxacin. Now, what kind of resistance is this? So, if there is resistance to only these two drugs, this is multi-drug resistance tuberculosis. Clear? And if there is resistance to these three plus fluoroquinolone, that is ciprofloxacin here, this is extensively drug resistance tuberculosis. Clear? So multiple drug resistance, extensively drug resistance tuberculosis. So in MDR-TB, there is resistance to isoniazid and rifampicin. In extensively drug resistance, there is resistance to isoniazid, rifampicin, plus any one injectable agent. Amikacin is given in this case here, right? So kanamycin is given, sorry, and any one fluoroquinolone. So any one fluoroquinolone, ciprofloxacin is given in this case, right? So this is extensively drug resistance tuberculosis, right? So with this we end today's session, and I'll be back shortly with some more subjects. Till then, keep on studying. God bless. Bye bye.